I'm Jim Erickson with Monteris. I'm our CFO, and I head up our marketing group as well. And I've got a couple of other Monteris colleagues with me here as well, Jennifer England and Lisa Hayden. But we're going to turn this over to Dr. Kim in just a second. The only thing I thought I'd lead with is, you know, the intent of this is to try to create a bit of a discussion, especially in this COVID world. We were trying to find ways to continue to help in the education process around new technologies like LITT, and learning from our experienced users seems to be the most productive way to do this. And Dr. Kim has been gracious enough to help share some of his learnings. And the platform we're doing this is with a case review. So he's going to go through some cases that he thinks, I think are good representations of things to learn. But we're hoping that this can be a dialogue or a discussion. So if there's questions, please feel free to jump in, and hopefully there'll be a good discussion that way. Dr. Kim's got a great amount of experience with LITT in general. He and his team at Washington University have been early on in the usage of LITT, especially in the glioma world, which is what our topic is about today. They've also, the team there's also been very involved in our work on our clinical registry that we're working on, both as contributors and as authors, and we thank him for that. And he's also been kind of a thought leader in the research and preclinical world around LITT in some of its combination and impacts to treatment in gliomas. So we're really grateful to have him join here because he's got a depth of knowledge around LITT and gliomas that not many have in the country. And so with that, Dr. Kim, thank you for joining us, and I'll turn it over to you.
Thank you very much, and thanks everybody for joining us. Again, my name's Albert Kim. You know, one thing about this bizarre time is the opportunity to really double down on real-time video conferencing and network and get information from colleagues. So I think that's been you know, a sort of surprising boon in this time, and hopefully this is just another example of that today. And please feel free to just interrupt me whenever you'd like. Again, my name is Albert Kim. I'm the director of the brain tumor program at WashU. I do a lot of laser cases along with my colleague, a good friend of mine, Dr. Eric Luthart, who did the first FDA approved case actually in 2010. And since then, it's been a wild ride. It's been a lot of changing. It took some open-mindedness at the beginning. So just to maybe give you a little background on me, I did my residency at Brigham and Women's Hospital, and then I did an open skull-based fellowship. So I came out of training thinking, oh, well, I'm going to do these maximally invasive approaches to take out tumors, and then I go to my faculty position. I meet Eric Luthart now a decade ago, and he's making these tiny 4.5 millimeter holes for laser and treating tumors like that. And I thought it was just nuts. I thought it was crazy. I mean, I just was at the beginning. I would just say to him, why don't you just take that out? What are you doing? And fast forward from that to now, and we've done 300 cases. And I would say I'm truly a believer in this technology for a variety of reasons. And so that was sort of where I came from. And so today I'll talk about a case series of my own cases of laser for glioblastoma and other gliomas. And hopefully each of these cases highlights a different concept. And again, feel free to stop me, please. This is just saying that these are my cases, and don't do this at home, I guess, or something like that. My disclosures. And so let's just start. So the first case is this 25-year-old right-handed gentleman who underwent surgery for surgical resection in March of 2017 at an outside hospital, and was found to have an IDH1 mutant anaplastic astrocytoma. So common stuff in the anaplastic astrocytoma genetic fields. And then he came to our institution more recently, where he was reevaluated based on his prior pathology, and we thought, our neuropathologist thought he had an IDH1 mutant grade 4 astrocytoma. So, I mean, what we used to call IDH1 mutant glioblastoma, but we just call it a grade 4 astrocytoma now. So then he underwent concurrent temozolomide, STUP protocol, chemoradiation, and then he had adjuvant temozolomide, and he's looking good. He's actually a cop as well, a young cop. So when he was seen at the other hospital, he had this multifocal lesion, maybe some wispy enhancement. as you can see on the left, on the T1 plus contrast, on the right, T2 axials, and then a very aggressive but appropriate surgery done at the outside hospital of 2 different foci, one in the left frontal area and one in the left temporal area. And so then you fast forward, and this is when I met him. He was being presented in our tumor board because he saw one of our neuro-oncologists. And the new thing, as you can see, not only did he have that the left opercular tumor and the temporal tumor, but he also has really extensive T2 bright tumor, which is not enhancing. I mean, this is really formerly what we would have called a gliomatosis cerebri type of picture. But the new thing is really here in the temporal lobe, and this is an area of nodular enhancement here, which had increased perfusion, and was associated with T2 flare signal abnormality, bulky disease as well. And so we discussed this case. We did additional advanced imaging as well, including at WashU, we do resting state clinically, and that revealed that the enhancing component in that temporal area was separate from Wernicke's. And then coming up with a plan together, again in multidisciplinary fashion, what we thought would be best for him would be a trial, actually, something based on a trial we have ongoing, which is essentially laser plus a PD-1 antibody or checkpoint inhibitor. Now, this family was really aggressive, so they basically came at me with like literature. They told me about, you know, the Nature Medicine paper, I think it was from UCLA, talking about neoadjuvant PD-1 antibody plus craniotomy, how that was, you know, seemed to be efficacious. So they just came out of the gates with all this information, and I said, fine, I think I'm great with that. We can do neoadjuvant checkpoint inhibitor and then get the biopsy and laser off trial, and then continue the neoadjuvant PD-1 antibody. Now, so one thing I would highlight here that the laser is interesting for is that it really, I think, enables some clinical trials that you otherwise wouldn't think about. We can get into that later because I don't think that's firmly in the mainstream in terms of like primary indication for using laser, but it certainly is an enabler just because you can come up with just sort of different hypotheses for using laser with other therapies in clinical trials, and that certainly is a draw for patients. And there's genuine excitement, at least on the part of my colleagues and myself, that I think some of these combinations could really be worthwhile. In this case, we always do laser with intraoperative MRI. You don't have to do that. You could place the probe and then go to a standard MRI in the neuroradiology imaging suite. We've also recently, I would say in the last 2 years, moved to a ROSA robot platform, both for neuronavigation and for, but essentially for neuronavigation, and also the base through which we do the drilling. I mean, this is like an automobile manufacturing robot that's been MacGyvered to work for neurosurgery. So you can literally do pull-ups on it, I would say, and it won't change the accuracy. And so, particularly for the long trajectories, I think the ROSA robot is critical. And so that's what we decided to do for this individual. And so here are some intraoperative shots where we have we use the Monteris mini bolt, and we screw that in through the ROSA robot base, and then we place the probe. Now, in general, Dr. Luther and I tend to use the diffusion tip probe instead of the side fire. And then we generally also put the power to 120%. Not because we're impatient, but I honestly think that will get the job done efficiently, effectively, and also accurately. And so here you can see the yellow TDT lines, which basically correspond to a heat threshold or dose of 43 degrees at about 2 minutes. It's not quite the kill dose, although that is a dose we use for radiation necrosis. And then here is the blue TDT line, and that is essentially the kill dose for most users, and that approximates basically 43 degrees Celsius for about 10 minutes. There is a white hot zone, which is super kill, I guess. That's 43 degrees at 60 minutes, okay, and that would be the white line. Now, me personally, I do that sometimes for METs if I can, just based on our experience with metastases. And so, let me see here. So we got good coverage of this lesion here, and in fact, we have a nice video of that. I think that may have started already. And what you can see is that the green basically tells you the area in which you can measure the heat, which is great. And then you can see the lines increasing with time. The yellow line again is the suboptimal, not suboptimal, but the lower heat dose, and the blue is the kill line ready, really. And so you could see as time goes on that that we're covering this T2 enhancing nodular area. So that you see it switching over from the yellow. And basically what you can achieve is you can see what the yellow, so yellow is sort of like looking into the future. It doesn't kill the tissue per se, but it tells you what the blue can achieve. So you'll see the yellow in front, the wave of the yellow in front of the blue, but you know that the blue can eventually reach it, okay? Now we did the biopsy as well in this case, and it turned out to be recurrent IDH1 mutant grade 4 astrocytoma. And so that was a pretty quick case, I would say. That took probably somewhere on the level of 15 minutes to heat up once the probe was in place. And this is about 1 month post-op, where you can see we covered the area of flare signal abnormality that used to be a lot bulkier. And this is the T1 with gadolinium. Now, again, it was about a recurrent IDH1 mutant grade 4 astrocytoma. The things I would emphasize here are that, number one, I think the patient and his family were excited because this was essentially an extension of a trial we already have ongoing, which is laser plus PD-1 antibody or checkpoint inhibitor. And so they were excited about that. There are other things I could say about that trial if you have any questions later. The great thing about this was that this was during the pandemic that I did this case. And he basically came in the morning, and he was discharged the same day. So before that, we were discharging people the next day, typically after a post-operative MRI, and that was really the thing keeping them. But during the pandemic, we've been pushing to get people out the same day, and people have been doing great. I would say I even got an 84-year-old out the same day who had a metastatic tumor. So I would say, I mean, just to be really honest about it, out of 15 people I did during the pandemic, 4 of them left the same day, and all but 2 of them left the next day. And I think the 2 that didn't leave the next day, they were basically rehab bound even before I did this procedure. So they went to rehab after that. And so I think that's a very interesting concept, especially doing this, the ablation, the brain surgery, and having them leave the same day. So the second case is very similar. I'll just go through it more quickly. There's a 69-year-old right-handed female who underwent surgery for resection in June of 2018 by myself. She has an IDH1 wild type, not a mutant tumor, GBM, MGMT unmethylated, so a really bad type of wild type, IDH1 wild type GBM. And she had subcortical radiation and then adjuvant chemo. And so she had this tumor in the right trigonal posterior parietal area on the right, and then I cut it out. This is just a little blood after the fact. And then she did quite well. But fast forward about, I don't know, I guess this is about a year, 2 years maybe. So she did quite well. There's a thalamic recurrence. I think this is just artifact here you see in the left posterior limb. This right thalamic sort of pulvinar tumor is really what we're talking about. And so what we did was, again, we had a multidisciplinary conference, and we thought that biopsy with LITT plus enrolling her in that PD-1 antibody trial would be a great choice for her. Again, we used intraoperative MRI and ROSA. And again, she was a same-day discharge, which was fantastic. And so she was very happy about that. Now, on the biopsy, it was recurrent IDH1 wild-type glioblastoma. And 2 months out now on trial, she has this area of eggshell enhancement around the thalamic lesion. Okay. Does anyone have questions about those first 2 cases? Again, that second case was done during the pandemic, and I thought it was great that we didn't have to use an ICU. So moving on, the third case is a 33-year-old right-handed male, young guy, right? He's not going to have much problems. He presented with headaches, and he went on MRI, which showed a mass in the right frontal lobe. Now, I met him after the first surgery. He had gotten a first surgery at the outside hospital, and he really presented to us for a second opinion. So, and he's intact. All right. And so when he presented to the outside hospital, he had something that looked like this. You can see this heterogeneously enhancing mass in the right frontal lobe. Okay. And so after the surgery at the outside hospital, his post-op looked like this. So essentially, they had taken out the T1 gadolinium enhancing region, but had left the T1 the T2 bright non-enhancing area. And on pathology, this was found to be an IDH1 mutant, anaplastic astrocytoma, WHO grade 2. Okay. So we were thinking about what we would do from next. I thought, well, maybe I could get the rest of that with laser. Should we get the rest of that even with a craniotomy or laser? Maybe I should just do a craniotomy. And so we thought of a number of different possibilities. The guy hadn't gotten, adjuvant chemoradiation yet. But at the end of the day, what we chose was to do a redo right frontal crani. Because quite honestly, if you look at that configuration, and it's above and below this too, it's like this sort of Pac-Man shaped area that's pretty large for laser. So that's one of the things we think about. I mean, you can really basically make a sausage that's 3 centimeters in diameter. But once you get to a certain size, and if we have time, I can talk about a case like this. If you get above a certain size, just like maybe just over a 3 centimeter diameter sphere, really, you start having a lot of edema potentially. So in this case, because of the size of this, because of the shape, I think it wasn't really amenable to just 2 trajectories. We decided on a craniotomy. And there are multiple reasons, I guess, to legitimate this kind of a surgery in this setting. I think the best literature for that is really by Dan Cahill from MGH. And they have a very nice paper from Neuro-Oncology where they argue that, and that he talks about IDH1 high-grade tumors in general, where basically argues that in IDH mutant tumors, if you have T2 and T2 bright non-enhancing regions, and you take out those areas in addition to the T1 gadolinium enhancing areas, that patient survival is much longer. And that's not always the case with IDH1 wild-type tumors, although that literature is also rapidly changing. Okay, so we decided to do the redo craniotomy, and we always do this with intraoperative MRI for our gliomas, and as you can see, I took out all of that T2 bright area, and he did great, and we're continuing to monitor him. He obviously got adjuvant temozolomide and radiation therapy after that, followed by adjuvant temozolomide by itself.
Say, Dr. Kim, not to back you up, but I do see a question that came in earlier. Somebody put in the chat that was just on your case 1. What happened to the infiltrative tumor in the left frontal brain as time went on in the case 1?
So this is a pretty recent case still. I just wanted to present it because of the same day discharge. And also because of that opportunity for a clinical trial with checkpoint inhibitor. But so that I really only saw him about a month out so far. I think he's going to get another MRI this month or shortly. Now the idea, hopefully, is that the LITT. So the hypothesis with the laser and the PD-1 in antibodies really that unlike number one, the laser might provide a danger signal to make immune cold hot. As people know, glioblastoma is traditionally very immune cold, and particularly IDH1 mutant tumors as well. And then number 2, unlike craniotomy, where you basically cut out the antigens, the neoantigens that could be responding, could be targets of the immune system. In the case of laser, you basically heat up the tumor cells, kill them, and then you leave the baked antigens in there. And so that's another as sort of as an NC2 vaccine hypothesis. And so those are the sort of 2 rationales. And we're working on biochemical or biological correlates for these hypotheses also in our trial. So that's the idea behind the trial. So then, if that's true, if you accept that as a possibility, those 2 hypotheses, then the T2 bright area might also be affected by some strategy like this. Because and in the end of the day, the laser's focal, right? And you're talking about a global or diffuse infiltrative disease. So there is some disconnect between the actual physical technology. I would argue craniotomy is the same way. It's focal or local, right? But I think there could potentially be changes in the microenvironment that we don't know about yet. Well, one thing we do, you can increase blood-brain barrier permeability for sure with a laser. That's one thing that you can get out of it. But we still don't know what happens to the sort of the microenvironment in terms of this immune milieu and other stromal elements. So I think that could also potentially synergize with other immune mediators or other therapies in a way that we don't know yet.
Yeah, I would agree. And my background also is outside being a neuro-oncologist. I'm a neuroimmunologist, and
Oh, great.
one of the things that's really important that you said is opening up that blood-brain barrier. And once that's done, cells don't really need a lot of things. They don't need a lot of new markers, and they don't need to be activated to get in. You could potentially, right after a surgery, understand that one, there's going to be cells wanting to get in to pick up any extra debris, any bacteria that, small pieces that were left over. The cells are going to want to get in and clean up some of the burnt, baked, leftover tissue there. All those cells getting in could also potentially happen to notice, sort of they call it the bystander effect, happen to notice antigens that they would have otherwise not seen because it's in this immune privileged compartment, the brain, and those cells would start to be activated then. So given the brakes taken off of the immune system at the same time, I can see how these trying to time well the use of PD-1 and PD-L1 inhibitors will be very effective.
Well, that's a very eloquent summary of of what we're thinking about for sure. Thank you. The other thing about the BBB and BTB permeability effect specifically, so Eric and I have a human study, and then I have a mouse study recently on this. They both align very well, actually. So after laser therapy, it seems as though in the vicinity of the laser, so locally, the blood-brain barrier or blood tumor barrier, either one, we modeled both in the mice, are open for about 1 month. So in humans, I think it's about 4 to 6 weeks. So that's a real opportunity. That's sort of a window of opportunity, either for immunological effects or even perhaps small molecule or even large molecule inhibitor effects. For instance, we could get antibody in during that period as well. So this is a 62-year-old female who presented with fatigue and some left lower extremity weakness. I performed a right frontal craniotomy this is a while ago now, November 2014, for near gross total resection. Again, IDH1 wild type, so TERT promoter mutant likely, EGFR MET and FGFR1 amplified, MGMT methylated, with tiny residual in the basal ganglia. I'll show you that, as well as the corpus callosum. So she opted to be enrolled in the DCVax trial. Really the conceptually pioneered by Linda Liao in UCLA, who's Dr. Liao is an impressive individual, obviously, a real giant in the field. And then this patient underwent STIP protocol chemoradiation after the DCVax. So the tumor, looked like this before the first operation, sort of medial frontal, kissing the basal ganglia, as well as in the corpus callosum there. And then this is the first post-op, and really most of this is blood, and there's very little left, if any, but if there's any, there's a tiny amount in the basal ganglion and corpus callosum. I could tell you in situ probably. And so let's fast forward from about a year or so, maybe a little less than that, and there's this growing area of nodular enhancement and just next to the right frontal horn in the vicinity of the cavity with increased perfusion, okay? And very suspicious for recurrence, obviously. And so our team gets together, and one thing we find out is I think she was on the placebo arm of the DCVax, so she elects to do crossover. And so our strategy here is to do laser plus get her on the crossover arm on the DCVax, and then continue her with adjuvant temozolomide. She was methylated after all. And then so we did this with, I think back then I didn't do this with a ROSA robot yet. Intraoperative MRI in stealth. I think it was even the Axis Space, which was even a generation before the mini bolt. Looked like a little UFO that you put on top of someone's head. And so this is a pretty straightforward treatment. I would say it's a lot like an EVD, right? An external ventricular drain for the neurosurgeons. And this was very expeditiously performed. I mean, the one thing it actually reminds me of is in the vicinity of ventricular spaces, heating can be a little slower. I remember, for instance, a low-grade glioma that I did a treatment on in the left trigone, in the left atrium, and I remember it was just sort of like a little cherry hanging in the trigone. And I remember thinking, wow, this is just taking so long to heat, and it's just because the CSF or or even nearby blood vessels actually can act like a tremendous heat sink, and just something to keep in mind. So things really in the vicinity of the ventricle may take longer to heat up, or you might not get as much effective heating. And you can see here the cumulative TDT lines. Again, here is the yellow line, and here's the blue line, where we get very good coverage, for instance. And immediately post-op, we have this nice coverage, looks very good, treatment of this area. Okay. Now, 5 months post-op, now it can look like this, the edges of a laser-treated zone. Now, in fact, it confuses some neuroradiologists sometimes, the appearance of these lesions after treatment. But I think overall she was doing well. But then let's fast forward yet another year. She has recurrence really on top of, superior to this lasered area. And at that point, she's on I think it was the Medi 41. I'm gonna misremember the number. It was a Medi trial though, but the long and the short of it was that it was a PD-L1 antibody plus Avastin trial, which she was put on. And then about several months out from that, she was put on hospice in January 2017. But I would say it's a very reasonable run she had in terms of her disease. If you think things started, way back when, really in 2014. Does anyone have any questions on that? So, I mean, another concept to bring up is I would never do just laser alone, really. I think that doesn't make it, personally, I don't think that makes a lot of sense, right? I mean, everybody knows that multiple orthogonal treatments is really going to be needed for this disease anyway. And so I would say you always have a, kick and a punch or something like that you put together to really make laser effective. Now, there is literature out there suggesting that if you can cover more of the lesion, things work better. For instance, what comes to mind is the Mohammedi paper that was done collaboratively also with our institution, where he looked at newly diagnosed GBM. Eric Luthart does more newly diagnosed GBM than I do, for instance. I do a lot of things like, for instance, like sort of deep periventricular or insular GBM is actually perfect for laser. But some people tend to also do lobar GBM in the newly diagnosed setting. I can say that in our experience with other institutions, the higher you get to 100% coverage of the contrast enhancing lesion, the better people do. And this was a comparison against biopsy, for instance. Our experience is mostly, I would say, with recurrent GBM, and this is published. In that space, the sort of the industry standard, the state of the sort of the, I don't know if it's called standard of care. There's no standard of care in recurrent GBM, but I guess the comparison people like to make in recurrent GBM is with CCNU and Avastin, right? That New England Journal trial. And in that study, what they were able to achieve was overall survival of 9.1 months. Okay, so that's sort of your state of the art, right? 9.1 months. Now, if you put all of our recurrent GBMs together that we did LITT on, now all of them were on different sorts of trials. So the granularity is not there, but just taking all comers, laser, recurrence in GBM, our overall survival, median overall survival, was 22.3 months. So well greater than the median overall survival of 9.1 months in the CCNU Avastin trial. So I think there's definitely an interesting effect that's happening.
Couple things. One, so the BLOB trial, that's that CCNU Avastin trial, really, like we said, failed because there was just no good overall survival, in that particular trial. And so the idea of I think you were maybe mentioning the Checkmate 143 trial, where they used bevacizumab and nivolumab. And the unfortunate thing with that trial failing was the heavy use of steroids, dexamethasone. And I would try to I wanted to kind of get your two things, wanted to get your input on how we would start to modify the use of steroids, which actually are the opposite of the PD-L1 inhibitors, the idea of not using steroids and instead using the Avastin, but timing that just so that there's not a high risk to bleed, after the LITT. And then your comment on maybe the inclusion of TT fields now for these recurrent or newly diagnosed tumors.
Those are all great questions. So the steroid question is really important. So, I mean, we've been stricter about the steroid usage. And in fact, the reality is that whoever thinks of another Avastin that's not, however hundreds of thousands of dollars it is really going to make a lot of money, honestly, because we need something other than steroids. So I think most people would allow, even in the checkpoint inhibitor trials, something on the order of 2 BID of dexamethasone. Is that right? Something.
Yeah, it goes
that's
up
what
to
my
4.
medical oncologist tell me.
Yeah,
Yeah.
up to
So
4.
if you go above that, then basically you're killing any effect of the PD-1 or PD-L1 antibodies. So what we've been trying to do is preoperatively really make sure that their steroid doses are low like that. And then even in the immediate postoperative setting, unless there's a significant mass effect question, I like to keep them basically 2 BID or lower. And so that's something we're very intentional about. Now, I think it's really interesting that you're saying the Avastin as an alternative, because we've been thinking about that. We've actually been using, I would argue, we've been using Avastin more for that reason.
Yeah, yeah. Yeah, I mean, it's 10 times more effective at mitigating the inflammatory. And as a matter of fact, insurance companies will pay for you to get it to a patient while they're inpatient if you don't talk about it as a biologic and you talk about it as an anti-inflammatory.
I think it's a great adjunct to a lot of the checkpoint inhibitor possibilities. I think that's a great idea. We've done that for sure. And, I think officially people say you should wait somewhere on the order of 3 weeks before or after Avastin, right, for surgical procedures, right? The 3-week window, I think, is basically what they want.
Yeah,
but honestly, with laser, you don't really have that much bleeding. And in fact, you have coagulated blood vessels in the middle of the coagulative necrosis zone. So
yeah.
I think likelihood of bleeding is actually not really as high as with a craniotomy. So I probably have suggested maybe 2 weeks after laser, even doing Avastin before.
Yeah, I like the idea. It helps to clean up any extra necrosis and prevent that expected 3-month window of the, T2 flare change over the next, after the LITT. I really like the idea. And the patients tolerate it.
And then you don't have the steroid, you don't have the steroid around to kill the effect of the checkpoint inhibitor. It's great.
Right. And the regular innate immune response.
Exactly. Great.
Thank
So
you.
the next one is a little bit different. This is going to be a low-grade example. This is I'm stuttering there in my writing there, is a 45-year-old gentleman with, he had a seizure basically, and he underwent a subtotal resection. He had extensive right frontotemporal insular tumor, and that I essentially did a large biopsy on of his right anterior temporal tip. So he was found to have Oligodendroglioma grade 2 with 1p19q co-deletion. And this was actually at a time when we weren't routinely doing IDH1 mutation staining, or what we do currently is foundation medicine for sequencing. And then he got temozolomide and radiation therapy after his basically a large biopsy. And so this is what his tumor looked like before that initial anterior temporal tip surgery, really. This is 2012, well, 8 years ago. And then after that, actually, the tumor responded quite well to the chemoradiation. It did shrink, and if you had a side to side here of the pre-op and after temozolomide radiation, you could see a clear difference. But then, as you can see over time, is this, and I think one of my colleagues likes to call it creep over time, because when you look more frequently, for instance, you look between June and, I probably did it every 4 months for a while, and October, then you would see very little change, but you put them all together over time and you see a fair bit of creep, as you can see here. I mean, in September 2019, that disease in the insula is pretty bulky, okay? And additionally, lower in the temporal area, medial and anterior temporal area, the disease has also gotten bulky, but he has no enhancement, okay? That's why I'm not showing the T1 gadolinium enhancing. Oh yeah, so here's that bulky anterior temporal and medial temporal area as well. And so we discuss him in tumor board, and what they suggest, what we suggested overall was a biopsy plus. And this is something that Dr. Luthar and I have been doing, 2-stage laser followed by adjuvant temozolomide. We're going to use intraoperative MRI, and I think for an insular pass, it is really critical to use something like Rosa Robot, just so you're dead on, really. And so let me just show you this again. So I mean, this is a really big area to treat with laser in one sitting. I mean, imagine treating this, having that swell up on you, and then also going down through this area in the temporal lobe, really right adjacent to it. Not to mention, you know, corticospinal tracts in the vicinity and things like that. And so I recommended an intentional 2-stage plan for the laser. And you know, with low-grade glioma, honestly, I think you have time to do this. You know, you can wait 2 to 3 months, 2 to 4 months in between treatments. And so what I decided on doing first was the insular trajectories. And traditionally, we've done insular through a parietal approach, really. To get the football shape of the insula, it's good to go behind sort of sensory area, for instance. And generally, you need 2 passes even for not so bulky disease, just to cover the sort of the football shape of the insula. So traditionally, we've done that. That works well. But more recently, you know, that pass goes really close to the posterior limb of the internal capsule. And so more recently, Dr. Luthard and I have been doing frontal through the forehead passes. And that seems to shape the heat in such a way that we can more easily avoid the posterior limb, is what we found. Now, I thought that would be cosmetically displeasing, but you know, you put in the wrinkles and it's literally a stab incision. I think it looks just fine, okay? And so these are the TDT lines from the first trajectory of the first stage, so the insular LITT, okay? And then this is really the second trajectory. So there's stacked trajectories generally for the insula, and this I came in from the front to avoid that corticospinal area more easily, okay, as you can see here. So those 2 crossing trajectories. And so if you look at the cumulative dose, again, the kill zone, the blue TDT line, you can see something like that here, as you can see here. Now, one thing I'll mention, there's literature out there about how much you can heat in terms of laser, the DTI generated tracks. So for instance, there's some papers out there, and forgive me for not remembering the senior authors, where I've heard that if you kiss or overlap the corticospinal tracts with the yellow line, there's a possibility of irreversible damage. Okay, that's some people's experience. There's literature like that out there. That is absolutely not our experience. What we've seen is that if you touch corticospinal tracts, for instance, with the yellow line, again, the sublethal line, then you don't, I have personally never seen a deficit with that. And I think a lot of this has to do with individuality of institutions. You know, probably the way DTI corticospinal tracts is done in Dr. Rodriguez's institution versus Dr. Weiss's institution varies greatly. I would bet money on it, you know, and because, you know, you can threshold it differently, you can have more fibers being shown. So I think it really depends. You need some experience with how your institution is doing it to know that you can really do something like touch the corticospinal tract DTI lines with the yellow zone. So fast forward to a couple months, and then I did the temporal area, and here's a good example of these TDT lines. This is yellow being real close. I mean, I would not expect this to have a problem. I mean, I've literally sort of gone into 2 or 3 millimeters into the corticospinal tract fibers and have not seen a deficit, for instance. So this pass was more parietal because I thought that would cover more of the rest of the area. And you can see the blue TDT lines here covering that medial temporal area, for instance, anterior temporal, okay? And then so what we could achieve, and this is a good representation of it, this is the pre-op insular temporal, and this is 4 months after stage 2. I mean, this is a really dramatic result, I would say, and this is all laser. And so the guy is going to get TMZ now afterwards. And same thing with this area of bulky T2 disease in the anterior medial temporal area. I mean, you can really whittle away at it for the low grade glioma specifically, and shape it and just get rid of a really bulky amount of tumor in a way I didn't really anticipate. And this is something that Dr. Luthar got me basically put my attention to originally, and then I've been doing it on multiple cases now. Again, if the tumor itself is too large, then just break it up into stages. And I think, for instance, I think this is a great result. One more case, if you're interested, or maybe I can take a few questions and I can show that last case, or whatever whatever you want. I don't actually know how long we're doing this still.
Hey, I forgot that the second part of my question was the use of TT fields afterward. The
I'm so
beautiful
sorry.
thing is that, oh yeah, no worries. I was going to say the beautiful thing is that the LITT doesn't require a giant open, resection with a lot of healing. It's potential that these patients could return to their use of TT fields quickly. And I mean, there's situations where they just cut away a little bit of the sticky pad so that it goes around that area that may have a little bit of a healing scar. So have you seen anything in your collaborations with the neuro-oncs and med-oncs to see if that's been an issue for them, or if they wanted to, kind of defer later the use of that?
Yeah, so I would say for us personally, just because of our profile of clinical trials, we tend to use it less in the newly diagnosed setting, although the evidence is better for the newly diagnosed setting for TTF Optune. We tend to use it more for the recurrent setting, and I know that evidence there is not as good. But regardless, I think if you use LITT, you have basically incisions that are tiny stab incisions. And I would say that if you wanted to do TTF right away, or frankly, temozolomide or radiation, or after a MET, for instance, a small molecule inhibitor right away, I think it's completely fine. I don't think there's any issue with wound healing because the wounds are so small. I think that's a great advantage.
Hi, you mentioned that it takes longer to heat up when there's a tumor next to the ventricle.
Yes.
In your experience, have you noticed whether or not the kinetics of the temperature rise changes the biological effect of LITT? So, for example, if it takes 5 minutes versus 15 minutes, do you see downstream differences in terms of response or necrosis or any kind of biological changes?
This is completely speculative, but in fact, what you just brought up is something one of the engineers, actually the chief engineer at Monteris, has talked to me about. He talked to me about something about some of the outliers in our LITT PD-1 antibody, because nobody else would have seen this except him, having had longer treatments. So actually, I have no control data to suggest that what you're saying is true, but actually I've heard that people say this before, that the time of the treatment might actually change the biological effect. Now, I don't know how that would work, but it's funny, you're not the first person to say that to me. I don't know how that would work exactly, but there could be something to that. I just don't know how to explain it right now.
Okay, thank you.
Is there data that already that a certain amount of time, that there's a certain amount of time at a certain temperature that matters, that allows for killing versus just disabling the cell? Isn't there already some LITT data?
There is, but I think based on the Arrhenius equation, which is what the TDT lines are based on, the blue should kill most cells. But I know in operationally speaking, different things are good for different pathologies. For instance, the yellow line is just fine for radiation necrosis. You're not really killing anything, I get. Although you're killing a vasculogenic process, I guess. In the case of mets, quite honestly, if I can, I try to do white hot, because early on I saw these failures with barely blue TDT line covered tumors that were really frustrating. And so I think it might really also depend on the pathology.
I have a
Even
quick
though
question. I've read both the paper you referred to, the Dr. Luthart paper in humans, and then your recent paper in Neuro-Oncology Advances in the murine models. And so I guess my question is, clinically, what has the paradigm been in terms of timing? So we know that the blood-brain barrier stays open for a period of time, and it seems like that period of time has a peak, maybe within that first week, but kind of stays open even after that. So I'm just curious, how many doses do patients get, and what's the time course? Is it a couple of days after surgery, or what have you guys been doing?
Yeah. So for the doxorubicin, you know what? I might not know the exact details to the doxorubicin trial, but in the doxorubicin trial, if I remember, it's within the first 2 weeks that they get it versus maybe month and a half later. That was the sort of the control setup. Although, quite frankly, that might still be penetrating brain at that point based on our data. So in terms of the PD-1 trial, it's not. It's a post trial. So anytime after I do the laser, they're getting that PD-1. Now, in terms of the PD-1, I guess one could make the argument that it's not necessarily only the BBB, but that it's maybe an immunological effect that's helping. But if we're talking about purely like getting a drug in with the LITT-induced BBB permeability effect, you really just have about a month. In medical oncology, typically people like to think about cycles, right? About like 6 cycles, 12 cycles. So I mean, realistically, you could only really get like 1 cycle, maybe the tail end of a second cycle in. So I think you bring up a really interesting point. I think it's a great start to a launch of a therapy, but we're probably gonna have to think about something else to also get other things in. Like if we wanted to do 6 cycles, what are you gonna do, right? So you get there 2 cycles in maybe. Then maybe you have to think about something like focused ultrasound or something else to continue the cycles. But that's a great question. I think it's still something we have to think about. People, I know you have a laboratory who's very interested in tumors, so I mean, we need to think about how we would think about that.
Yeah. And I guess my second question is just in regards to the DTI. So we use Synaptive, that kind of software that just generates tracks for us off of the DTI automatically. What do you guys do? I'm just curious how you get your tracks done. Do you use software, or are you doing it manually?
Oh, so I think it's a hybrid. So I think there is software. I don't remember which one, what they're using, but basically neuroradiologists provide it. So it's manually seeded and corrected. So that's why I think it's, because it's more than one case where I've actually gone into the yellow, where I've had the yellow TDT line go into the corticospinal tract and had no issue. Whereas other places, they're like, you can't do that. So I believe there's a consistent way they do it, at least with the neuroradiologists here. But it's neuroradiology plus the software for them.
Okay.
Hey, Dr. Kim, it just was a great presentation. I always like to, see these and they're always different, and that's interesting to me that they come out. These presentations turn out, different. You get more information. I appreciate the fact that you really talk a lot about the neuro-oncologists and their role being able to back up, not LITT by itself. Have you thought about, since it's sort of a re-emerging issue in our field, the abscopal effect and the potential for this local therapy to treat 1 or 2 mets in a multi-met, patient to have be of an impact for these patients?
So scientifically, that concept's so alluring, right? Basically you can exponentially increase the impact of your one treatment, because maybe you can globally activate the immune system and treat the other Mets just by treating one Met. Now, abscopal effect was first described in radiation therapy, but it's an immune effect for sure.
Right.
Now, I know a lot of people have been whispering about abscopal effect in LITT, and I do believe it can exist, but I just haven't seen robust examples of it, at least not like radiographic ones that are so clear to me. That being said, I can tell you just preliminarily, and this is super preliminary. Well, it's already been an abstract, so I guess it's been out there. But the preliminary data that we have with laser and the PD-1 antibody is that there is a signal. Now, it doesn't work for everyone, but it seems like you can stratify people who get pembrolizumab alone versus pembrolizumab plus laser.
Thank you, Dr. Kim. Fascinating as always, and some great insight and information to share. So thank you for joining us, and thank you for taking the time.